Welcome to Reimagine Healthcare. I'm your host, Noah Voles. So, last episode we met Kathleen, 46 years old, small business owner, 2 teenagers, and 3 years of just fatigue, brain fog, chronic pain, constipation, despite being on thyroid medication. Despite having labs that her doctors described as acceptable, despite seeing both a primary care physician and an endocrinologist who just increased her dose and sent her home. We talked about why the standard thyroid framework, the one built around TSH and T4, is missing most of the biological story. We talked about those deodyinase enzymes that convert inactive T4 into active T3 in your tissues. We talked about how the pituitary gland can be satisfied while the rest of your body is running low. And we talked about how Hashimoto's thyroiditis isn't just a thyroid disease, but like a systemic autoimmune condition that standard treatment doesn't really address at its root. Today, we're getting specific. We're talking about the labs. What should actually be measured? Why the standard panel is insufficient for, a meaningful number of patients. And this is the part where I think we can do better, why even when the right test is ordered, it might be run with the wrong method, producing a number that looks precise and authoritative, but may be misleading. Because here's the thing, in medicine, what you measure determines what you find, and what you don't measure, what you assume is fine, what you consider irrelevant, what your lab panel simply doesn't include, that determines what you miss, sometimes for years. Kathleen's labs had been telling an incomplete story for 3 years, not because the numbers were fabricated, not because her doctors were incompetent, but because the map they were using was missing most of the terrain, and today we're going to build the complete map. So let's start with the test that anchors virtually every thyroid evaluation in this country. TSH, thyroid stimulating hormone, is produced by the pituitary gland. We talked about this last episode. It's the thermostat reading. When thyroid hormone levels in the bloodstream fall, the pituitary pumps out more TSH to stimulate the thyroid to produce more. When levels are adequate, TSH backs off. High TSH usually means the thyroid is underperforming. Very low TSH in someone on thyroid medication usually means they're getting too much. And I want to be fair to TSH here. For initial screening, for identifying the 2 extremes of thyroid dysfunction, for monitoring gross adequacy of treatment, TSH is a reliable and well-validated tool. It does what it does reasonably well. But it has 3 fundamental limitations that make it dangerous to use as your only guide. First, TSH measures what the pituitary is experiencing, not what the rest of your tissues are experiencing. And the pituitary is uniquely good at managing its own local thyroid hormone supply. It's packed with that D2 enzyme we talked about last episode, the activating enzyme that converts T4 to T3 locally. So the pituitary can satisfy its own T3 needs even when peripheral tissues, your liver, your muscles, your gut, your brain, are running low. A patient on levothyroxine can have a perfectly normalized TSH while their liver is still relatively hypothyroid, their muscles are still sluggish, and their cognitive function is still impaired. The pituitary is satisfied, the rest of the body is not. And TSH will tell you nothing is wrong. Second, TSH doesn't reflect what the deodyinase enzymes are doing in peripheral tissues. Remember, the balance between activation and inactivation of thyroid hormone happens at the tissue level, controlled by enzymes that don't show up in any blood test. chronic illness, inflammation, autoimmune activity, nutritional deficiencies, severe stress. All of these can suppress peripheral T4 to T3 conversion, while TSH sits comfortably in normal range. The thermostat says the system is working. The rooms are still cold. Third, and this one doesn't get talked about enough, the reference range for TSH was established using population data that included people with undiagnosed thyroid disease. Think about that. When researchers collected blood samples from what they called a normal population to establish what normal TSH looks like, some of those people already had early Hashimoto's. Some already had subclinical hypothyroidism. When you include people who are already underperforming in your definition of normal, your upper limit of normal shifts upward. In 2006, researchers Wartofsky and Dickey published a landmark analysis in the Journal of Clinical Endocrinology and Metabolism. They found that when you exclude people with thyroid antibodies, family history of thyroid disease, or visible goiter from the reference population, the true healthy upper limit for TSH is closer to 2.5. The commonly used range goes up to 4.5 or even 5.0. That's not a small difference. For a lot of patients, that gap is the difference between being told your thyroid is fine and actually investigating what's wrong. So what about free T4? Free T4 is the unbound, biologically available form of the prohormone, the form that can actually get into tissues, and it's a useful measure. If free T4 is genuinely low, the thyroid is underperforming. Full stop. Free T4 is important at diagnosis, important for confirming overt hypothyroidism, and important for identifying a rare condition called central hypothyroidism, where the pituitary itself isn't producing enough TSH. And here's a methodological note worth knowing. The immunoassay that most labs use to measure free T4 is actually reasonably accurate. You can generally trust that number from a reputable laboratory, but free T4 alone tells you nothing about what happens after the prohormone leaves the bloodstream. It tells you nothing about conversion. It tells you nothing about whether T4 is being efficiently transformed into T3 in the tissues. It tells you nothing about whether the active hormone is actually reaching the cell nucleus and doing its job. Think of free T4 as measuring whether the pantry is stocked. It tells you the ingredients are there. It does not tell you whether a meal is being cooked. It does not tell you whether anyone at the table is being fed. For patients on levothyroxine, which is pure T4, free T4 is particularly limited as a measure of treatment adequacy. The entire therapeutic bet of levothyroxine is that the deodenase system will convert that T4 into T3 efficiently and distribute it to the tissues. For most patients, that bet pays off. But for an estimated 10 to 15% of patients who continue to feel unwell despite normalized TSH and free T4, that bet has not paid off, and free T4 cannot tell you why. Which brings us to the number that actually matters most. Free T3. T3 is the biologically active thyroid hormone. It's the molecule that binds to receptors, enters cell nuclei, regulates gene expression, and drives every physiological process we associate with adequate thyroid function. Every clinical effect of thyroid hormone, energy, mental clarity, healthy metabolism, stable mood, gut motility, normal body temperature, proper heart rate, is ultimately mediated by T3, not T4, T3. Given that, it seems almost incomprehensible that free T3 is not universally included in thyroid panels. The conventional justification, still taught, still practiced, repeated in guidelines, is that free T3 is not necessary for diagnosis or monitoring, that TSH and free T4 are sufficient. Antonio Bianco, who, as we discussed last episode, spent decades studying thyroid physiology at the molecular level, describes this position bluntly. It reflects an incomplete understanding of thyroid physiology, one that persisted in clinical medicine long after the basic science moved past it. He's not wrong, and here's the proof. If T3 is the active hormone and everything we care about clinically is driven by T3, then not measuring T3 is like managing a patient's diabetes without ever measuring blood sugar. You're measuring a proxy. You're measuring what the pancreas is doing, but you're never looking at the thing the pancreas is supposed to be controlling. Now, here's where it gets more complicated, and where the system really doesn't make sense. Even when free T3 is ordered, even when a physician takes the step of including it, there is a serious problem with how most laboratories measure it, and most patients and many physicians don't know this. There are two methods for measuring free T3. The first is an immunoassay. This is what most standard labs default to. It uses antibodies to detect T3 in the blood sample. It's fast, it's cheap, and it's widely available. It's also, according to thyroid specialists, unreliable, particularly at lower levels of T3, which is exactly the range that matters most in hypothyroidism. The second method is liquid chromatography tandem mass spectrometry, LCMS/MS. This method measures T3 directly and precisely without relying on antibody detection. It's more expensive, it requires specialized equipment, and it is significantly more accurate, particularly at the lower end of the range. Research published in 2016 in the journal Clinical Biochemistry compared immunoassay to mass spectrometry for total T3 measurement. At low T3 concentrations, mass spectrometry identified significantly more patients with genuinely low T3 compared to immunoassay. The study found that immunoassay classified many patients as having normal T3 when mass spectrometry showed they were below the reference range, with discrepancies of 20 to 45% in the low range zone that matters most for hypothyroidism. The immunoassay was giving false normal results nearly half the time in the range that matters most. A comprehensive review published in the Journal of Clinical Endocrinology and Metabolism in 2016 summarized the evidence. Immunoassays for free thyroid hormone are affected by alterations in serum binding proteins. Multiple studies show falsely normal values for T3 that are below the reference interval when measured by mass spectrometry. The correlation between immunoassay results and TSH is inferior to the correlation with mass spectrometry measurements. In other words, mass spec values track better with both the pituitary's assessment and the patient's actual symptoms. Now here's a comparison that might make this land harder. In the world of sex hormone testing, this exact problem is well recognized. Any physician managing testosterone therapy knows you do not use an immunoassay for testosterone. The immunoassay is considered clinically unreliable, and most serious practitioners discard it entirely. They specify LCMS/MS. The mass spec method is considered standard of care for testosterone measurement. The free T3 problem is directly analogous. The measurement is technically more challenging than testosterone. The immunoassay is less reliable at the levels that matter clinically, and yet the medical community has been far slower to adapt. Most standard labs, including major national laboratories, default to immunoassay for free T3 unless mass spec is specifically requested. So what does this mean practically? It means a physician can order free T3, get a number back, look at it, and make a clinical decision based on a measurement that may not accurately reflect what's happening in the patient's body. The test was ordered, the result came back. The number looked fine, and nobody in the system flagged that the method used to generate that number wasn't the right one. For patients in Southern Oregon who want a precision-free T3 measurement, you need to specifically request LCMS/MS methodology when your doctor orders free T3. In Jackson County, Quest Diagnostics in Medford offers mass spectrometry free T3 testing. LabCorp locations in Medford and Grants Pass can also run these panels. If you're using Asante Rogue Regional or Providence Medford, ask your physician to specify LC-MS/MS methodology or mass spectrometry on the lab order. Otherwise, you'll likely get the standard immunoassay. Cost matters too. If you're paying out of pocket, expect roughly $50 to $80 for a standard free T3 immunoassay versus $120 to $180 for the LCMS/MS method. A full extended thyroid panel with all the tests we'll discuss today typically runs $300 to $500 without insurance. Some patients choose to use direct-to-consumer lab services and pay cash rather than navigating insurance coverage, though you'll need a physician to interpret the results either way. Now let's talk about reverse T3, because this is the test that almost nobody orders, and that can tell you something that no other test can. We touched on reverse T3 in episode 1, but let's go deeper. When T4 gets converted by the iodinase enzymes, there are two possible outcomes. If the outer ring iodine gets removed, you get active T3. If the inner ring iodine gets removed, you get reverse T3. Structurally similar molecules, biologically completely different. T3 opens the lock. Reverse T3 can't open anything. And here is why reverse T3 matters clinically. When the body is under physiological stress, serious illness, fasting, chronic inflammation, autoimmune disease, severe psychological stress, the deiodinase balance shifts toward reverse T3 production. D3, the inactivating enzyme, ramps up. D1, which normally clears reverse T3 from circulation, gets suppressed. More reverse T3 gets made, less reverse T3 gets cleared, and it builds up in the bloodstream. The net effect is a patient who has adequate or even normal-looking levels of T4 and TSH, but elevated reverse T3 and low to normal T3. The conversion machinery has been shifted into inactivation mode. The body is deliberately throttling its own thyroid activity, and the standard panel will not capture this at all. The ratio of free T3 to reverse T3 is the best available blood-based window we have into the deiodinase balance. It's the closest thing we have in routine clinical practice to understanding what's happening at the tissue level. A ratio above roughly 0.2, when both values are measured in comparable units, suggests reasonably balanced diodinase activity. A ratio significantly below 0.2 suggests the system is running in suppression mode. Note: optimal ratio thresholds vary by laboratory methodology. Work with your physician to interpret your specific results. More inactivation than activation. More reverse T3 than active hormone getting through. Now, the reverse T3 assay has its own methodological limitations. Like free T3, it's better measured by mass spectrometry than immunoassay. And immunoassay values can vary significantly between different laboratories. So here's the practical guidance. If you're tracking reverse T3 over time, use the same laboratory. The absolute value matters less than the trend and the ratio. Cross-laboratory comparisons using different assay methods are not reliable. Let's talk about the antibody tests, because most patients with Hashimoto's get their antibodies checked exactly once, at initial diagnosis, and never again. And that is a missed opportunity. TPO antibodies against thyroid peroxidase, are checked at diagnosis to confirm Hashimoto's as the cause of hypothyroidism. The result comes back positive. The physician makes a note. And then, in most cases, the conversation moves on to dosing levothyroxine and monitoring TSH. But here's what those antibody levels are actually telling you. They're a dynamic marker of how active the autoimmune process is. If antibody levels are high and rising, the immune system is actively and aggressively attacking the thyroid. If they're falling, something is modulating the immune process. Maybe a treatment intervention, maybe a lifestyle change, maybe just natural fluctuation. If you only check once, you have a single data point with no trend. You know the disease exists. You have no idea whether it's accelerating, stable, or responding to anything you're doing. There's also a second antibody worth measuring: anti-thyroglobulin antibodies. Anti-TG, these target thyroglobulin, which is the protein scaffolding on which thyroid hormones are assembled. Anti-TG can confirm autoimmune thyroiditis even in the minority of Hashimoto's patients whose anti-TPO comes back negative or borderline. And tracking anti-TG over time, just like anti-TPO, provides information about the trajectory of the autoimmune process that a single measurement cannot. Now let's talk about something that falls completely outside the standard thyroid panel, but is critically relevant to why some patients don't respond adequately to thyroid medication. The nutritional cofactors. Remember the deodyinase enzymes, D1, D2, D3. Those enzymes don't work in a vacuum. They are biological machines that require specific raw materials to function, and deficiencies in those raw materials can impair conversion even when the thyroid is producing adequate T4 and the medication is being taken correctly. Selenium is the most important. The deodyinase enzymes are selenoproteins. That means selenium is a structural component of the enzyme itself. Without adequate selenium, the deodyinase enzymes don't work properly. T4 to T3 conversion slows. Reverse T3 can accumulate. The conversion machinery runs inefficiently even if there's plenty of T4 available to convert. And here's a regional note that matters for Southern Oregon specifically. Selenium in the soil varies significantly by geography. Parts of the Pacific Northwest, including areas of Southern Oregon, sit in regions where selenium soil content can be on the lower side. That doesn't mean everyone in this region is selenium deficient, but it means dietary selenium intake from locally grown food may be lower than in other parts of the country. For patients with Hashimoto's, adequate selenium isn't just about conversion efficiency. Multiple clinical trials have shown that selenium supplementation reduces anti-TPO antibody titers. It slows the autoimmune attack on the thyroid. This is not speculative. It's published, replicated research. Iron and ferritin. This one surprises people. Most patients associate iron deficiency with anemia, but thyroid peroxidase, the enzyme that builds thyroid hormone in the first place, is an iron-dependent enzyme. Iron deficiency doesn't just make you anemic. It directly impairs thyroid hormone synthesis. And critically, many of the symptoms of iron deficiency overlap almost perfectly with hypothyroid symptoms. Fatigue, brain fog, cold intolerance, hair loss. A patient who appears to have inadequately treated hypothyroidism may actually be iron deficient, or dealing with both problems simultaneously. and nobody has checked the ferritin, the threshold worth knowing. A ferritin below about 50 to 70 nanograms per milliliter can impair thyroid function even in the absence of overt anemia. This is a level that many labs consider within the reference range. A ferritin of 25 might not flag as abnormal on a standard lab report, but for thyroid hormone metabolism, it's meaningfully depleted. Vitamin D. Southern Oregon gets real sun in the summer, but we also have long, gray winters, and the vast majority of people who work indoors are significantly vitamin D deficient for a substantial portion of the year. Vitamin D is not just a bone health nutrient, it is a critical regulator of immune function. Low vitamin D is associated with increased autoimmune activity broadly, and with higher anti-TPO antibody titers specifically. Optimizing vitamin D, getting levels to somewhere between 50 and 80 nanograms per milliliter is low cost, low risk, and supported by evidence in the context of autoimmune thyroid disease. Zinc. Less discussed, but genuinely relevant. Zinc deficiency impairs the conversion of T4 to T3. Small trials have shown that zinc supplementation can improve thyroid hormone metabolism. Zinc deficiency is not uncommon in populations with poor dietary diversity, significant gastrointestinal issues, or high physiological stress, all conditions that overlap with the hypothyroid population. None of these nutritional assessments are exotic. They're not functional medicine fringe. They're basic biochemistry. Any physician caring for a patient with persistent hypothyroid symptoms, despite adequate hormone replacement, should be asking whether the enzymatic machinery that processes that hormone has everything it needs to function. Now let's put this together. Let's talk about what Kathleen's lab should have looked like from the beginning. What she received. TSH free T4, anti-TPO, checked once at initial diagnosis. That's it, for 3 years. What was missing? Free T, 3/LC-MS/MS, reverse T3, the free T3 to reverse T3 ratio, anti-TPO tracked over time, anti-thyroglobulin antibodies, ferritin, 25-hydroxyvitamin D, selenium. None of those are exotic tests. All of them are available at major reference laboratories. Several of them are available at any standard lab. The question was never whether these tests existed. The question is why nobody ordered them. And here is where I want to be honest about why this happens, because it's not negligence, it's educational. Many PCPs and endocrinologists were trained in a framework that considers TSH and free T4 sufficient and haven't been exposed to the research that challenges this. It's systemic. Standard electronic health record order sets default to the minimal panel, and deviating from defaults requires deliberate action in the middle of a 15-minute appointment. It's economic. Insurance coverage for extended thyroid panels is inconsistent. Prior authorization takes time that physicians don't have, and patients who don't know to ask for more comprehensive testing don't ask. The result is a system where the path of least resistance for physicians and for the system is the minimal panel, and the patient pays the price. So let me give you the practical roadmap, what to ask for at your next appointment if you have hypothyroidism or persistent hypothyroid type symptoms. Your thyroid lab checklist. Take this to your next appointment. TSH, free T4, free T3, request LCMS/MS methodology specifically. Reverse T3, anti-TPO antibodies, anti-thyroglobulin antibodies, anti-TG, ferritin, vitamin D, 25-hydroxy, selenium, If your physician asks why, I'm still having symptoms despite treatment, and I want to make sure we're not missing conversion issues or nutritional deficiencies that could be affecting how my body uses thyroid hormone. For ongoing monitoring, if you're on thyroid replacement, ask for TSH, free T4, free T3 by LC-MS/MS, and reverse T3 if your symptoms persist or worsen. Ask your physician to calculate the free T3 to reverse T3 ratio, and ask for anti-TPO to be rechecked at least annually so you can track the trajectory of the autoimmune process over time. Now, let me tell you what Kathleen's extended labs actually showed, because this is the payoff. Kathleen brought her research to her primary care physician, presented it carefully. Her physician, to her credit, listened. She pushed back on a few items, explained her limitations around what insurance would cover, and agreed to order what she could. She ordered free T3 by LC-MS/MS. She ordered reverse T3. She checked ferritin, vitamin D, and selenium. When the results came back, they told a story that 3 years of TSH and free T4 measurements had completely missed. Free T3 by mass spec, low normal, not dramatically low by the reference range, but meaningfully low in the context of a patient with persistent symptoms. Reverse T3, elevated. The free T3 to reverse T3 ratio, 0.075, well below the 0.2 threshold, evidence of significant deodyinase suppression, the body running in inactivation mode, ferritin, 18 nanograms per milliliter. Iron stores so depleted they were impairing both thyroid hormone synthesis and hemoglobin production, a level that sat within the official reference range but was nowhere near adequate for optimal thyroid function. Vitamin D, 22 nanograms per milliliter, significantly deficient, contributing to ongoing autoimmune activity, elevated antibody levels, and a system running with insufficient immune regulation. Selenium, bottom quartile of the reference range, not enough to support optimal deodyinase function, not enough to provide the antioxidant protection the thyroid needs during the inflammatory peroxidation reactions that produce thyroid hormone. None of these findings were dramatic outliers. None of them would have triggered a critical alert in a standard lab review, but together they painted a completely coherent picture. A picture of a patient whose thyroid hormone conversion machinery was running on depleted fuel, whose autoimmune process was ongoing and unaddressed, whose standard treatment had been optimized for the pituitary satisfaction rather than the peripheral tissue's needs. For the first time in 3 years, Kathleen had a map that matched the terrain, and her physician, looking at those results, didn't dismiss them, didn't look for another explanation. She looked at the picture and said, "Okay, this makes sense. Now we know what we're dealing with. Now we can do something different." That conversation, the one that should have happened 3 years earlier, is the subject of episode 3. We're going to talk about what treatment actually changed for Kathleen. We're going to dig into the evidence for combination T4 and T3 therapy versus levothyroxine alone. We're going to look honestly at the debate around desiccated thyroid extract, cutting through the ideology on both sides to find the actual science. We're going to talk about what functional medicine gets right in thyroid care and where the evidence gets thin. And we're going to make a direct argument for what Southern Oregon's healthcare infrastructure needs to build so that patients like Kathleen don't have to wait 3 years, do their own research, and advocate for themselves just to receive care that the science has supported for years. Because the labs were just the beginning. Getting the right diagnosis is step 1. The treatment question is where it gets even more complicated and even more important. Here's the cliffhanger I'll leave you with. In Kathleen's case, the lab results showed that her conversion machinery was suppressed, but she had been on Armour Thyroid, a medication that contains both T4 and T3. So the question isn't just whether she was getting T3. The question is whether the T3 she was getting was working, why it might not have been, and what the research says about the different ways to deliver combination therapy and which ones the evidence actually supports. Because it turns out not all combination therapy is created equal, and the difference between the options that work and the ones that don't is more nuanced than either camp in the thyroid debate wants to admit. Episode 3 is where we work that out. If this episode helped you understand what labs to ask for, there are 2 ways to stay connected. First, subscribe to our newsletter at reimagine-healthcare.org. Second, if you know someone who's been told their thyroid is fine, but still feels terrible, share this episode with them. Thanks for listening to Reimagine Healthcare. I'm Noah Voles. This podcast is investigative health journalism. It's not medical advice. I'm a clinician acting as a journalist and healthcare advocate. The goal of this series is to help you ask better questions of your own physicians, not to replace their judgment. The research we're drawing on is real and peer-reviewed, but medicine is complex, individual circumstances vary, and any decisions about your health should be made with a qualified provider who knows your full picture. Thanks for listening.